I think for me, the main kind of insight or aha moment had to do, first of all, with, of course, understanding the complexity of this problem in financial incentives in the health system. I appreciated that partly before, but the forum really, the dialogue really drove home that problem. And I think secondly, the issue of the interplay of the different kinds of funding channels and how they relate to incentives, and again, the complexity and the difficulty of thinking through the interactions of them to come up with good policy recommendations. I think was a very important insight or lesson that came out of the day for me. Well, I think for me, again, this idea of complexity in the interaction both between different sectors, different funding streams, another point of emphasis was the idea of incentives alongside non-financial incentives as addressing policy questions. So for me, the challenge, the next step is to think about how do we bring these different groups together so that any use of financial incentives can be placed in the context of a broader array of policies in which they will also be operating, so that we understand the context better and that their role can be defined, and we can ensure that the different policies, not just incentives, but the incentives next to other policy mechanisms, are aligned and they're coordinated and they're working together for the kinds of policy change we want. And I think that's going to mean bringing more people into the discussion than perhaps has been the case previously as people thought about financial incentive policies.
Well, I think the main insight, and it was structured by the facilitator of the session, was to make a specific assessment about where you stand on financial incentives. So coming into the session today, I hadn't approached it that way. And it was laid out, do you agree that they have value? Do you agree that they need to be changed, or should we just do away with them? So I think most people, as I was, were coming down the middle, that I think they have value, they need to be updated and restructured. But as the session went on, I think, I was getting a little bit more to, well, maybe they don't have as much value. There was a lot of discussion about, the amount of effort to put incentives in the system, and are we better to look at other levers to affect change. This is a session that's based on evidence. So one of my takeaways is how do we organize better to evaluate the evidence and put it out into all sectors in the system. I've recently joined the LIN, so I'm focusing now, how can I better use financial incentives and incentives in general at the LIN level and make it very evidence-based, and also to share the success through, I would say, formal evaluations of how they're impacting patient care.
I think the biggest challenge for us today is we're all working very hard to achieve outcomes that will produce high quality care, and often don't have the time to really step back and take a look at, is what we're doing the best way or the most effective way. I think the ability to utilize financial incentives will provide the opportunity to really give permission to healthcare providers to develop a solution or a new way of delivering care that really will go beyond the historical silos that we've operated within. I think the incentive to get people to dialogue about what the problem is, understanding who needs to be part of the conversation, and giving opportunity to remove or provide support so that they have the capacity to do that. I think that's critical for us now when we're looking at the challenges coming before us. I think having incentives at the beginning of the system, having the communication, allowing people to develop and design programs, and then also going back to where the aha for me is really understanding that we're not going to get it right the first time. So having an incentive that really isn't focused on perfection, but really enabling us to evaluate, rework, refine, and continuously improve. I think what really resonated with me was around we've utilized financial incentives in our system for many years, but often we don't take the time to go back and really evaluate the effectiveness of that incentive, and is it achieving the results that we were expecting. And I think for us now going forward, really understanding where an incentive will influence the behavior or outcome is a tremendous opportunity for us.
So let me start by saying that it's not as if we have been doing nothing so far. So it is how can we enhance what we are doing, how can we do some things different, and how can we fast track what we are doing in many ways. And I think it's at all the layers. It's at the macro level of government. I was speaking with some of the participants that come from government today about the issue of public engagement and why is it that it's not sufficiently happening. I think that on the issue of both accepting that at times we make a health system transformation that is not successful, and being able to very quickly analyze and retweak accordingly is something that we are not very used to do. We believe that we do health system transformation and it's kind of a set song sheet. No, it needs retweaking, and I think that we need to mature as a health system and know that whether it's at the macro, at the meso, or at the micro level of professionals, that we will need to retweak. The perfect example at RNO is the evidence-based practice guidelines program, right? Yes, it's quite tremendous. Yes, it's being used across the world, but we are constantly retweaking. We are constantly, as new evidence comes, for example, about more rigorous ways to develop guidelines or more rigorous ways to do KT. And now with all the area of evaluation that we are engaging, no doubt we will need to continue to retweak. And in fact, if we don't do, we are staying behind. If we don't do the initiatives, whether it is best practice guidelines or in this case, health system transformation, which is even more enormous, if we don't retweak, it means that we are not using the latest evidence to bear into where we are taking the system. So we shouldn't see it as failures. We should see it as normal part of the process. An important aha moment is that we need to differentiate between current incentives and future incentives. Current incentives, to a certain degree, will be very difficult to do without them, but we can repurpose them. We can repurpose them to outcome-oriented initiatives that will improve health system performance and patient outcomes, as well as the new ones. Then we need to think if we need them at all. So before we run with more and more and more incentives, let's do a very good diagnosis of what are the issues, and are those issues solved with financial incentives versus other policy tools that we have at our disposal. The other piece that is critical, and that we continue, in my view, not to leverage and utilize to its fullest, is public engagement. And to me, actually, that is the biggest incentive. If you look at a well-educated, well-engaged citizen, and if you just multiply that by hundreds and thousands, I think it will become an incentive for the health system to change to respond to what the public is saying are their priorities. Likely we will end up with much less procedures and much more quality of life at certain stages in life. And we will end up with a more open and transparent discussion and dialogue. And they will understand then that rapid cycles that enable us to bring innovation, whether it is through financial incentives or through other policy tools, require tweaking, that you don't necessarily get it right at the beginning. For that it's important though to have an enlightened public that will be willing to go along with the retweaking, that will not see it as a political failure. And I believe that that's completely doable. And by the way, there is quite a bit we can learn about public engagement from the UK that has been doing huge amounts of public engagement for decades.
Okay, so I'll speak from the context of what my organization does. I'm with the Registered Nurses Association, and I'm the Associate Director for Research and Evaluation. So we look at the implementation of best practice guidelines for nurses, for the nursing profession, and how that affects patients' outcomes. So to me, when I think about financial incentives, I'm thinking about how can the incentives actually help those who are doing the data collection from across the healthcare sector, which we collect. The frontline staff at the hospitals, how they are collecting the information that we need to do the evaluation and the research and evaluation and the monitoring of the indicators, that's the BPG indicators, the best practice guideline indicators. So I see that it will be helpful to channel some of the funding towards the frontline staff who actually go to collect data for the purposes of recording and monitoring the implementation of the best practice guidelines. It will be a nice way for them to have the extra support to actually begin to move from paper-based documentation to electronic. We've all heard about e-health, electronic medical records. So it will be a nice transition if they can get that support. The healthcare institutions can get that support to move from the paper-based to electronic medical records, which will facilitate the data gathering and the data submission that the frontline staff have to do to send to the RNAO to evaluate the BPG implementation across the healthcare sector. So it was talking about the incentives. So to me, four things came to mind. So the first one was sustainability of the goals, system goals that will be set or that have been set. And the second one is continuity of care in light of the goals that have been set or in light of the incentives that have been provided. How can we ensure that the care that patients are receiving will continue should the funding or the incentives stop? Will there be a continuation of care? And the third one is we have to think about incentives and the patient outcomes as a whole. And the fourth one will be the discussions around cross-sectorial discussions of different ministries like education, health, correctional services, and social services. These are all sectors of government that have impact on the personhood or the patient, just to say a patient. So the deliberations, the dialogue, the discussions that we had, I picked up on these four areas and I was like, these are important areas that we should be talking about going forward because they all affect the patient. We are all after patient-centered care, patient outcomes. So we have to think about sustainability, continuity of care, and the overall how financial incentives affect patient outcomes. So that would be the thing that I will talk about as the aha moment for me. Other than that, the only other thing that I also gathered from the deliberations was the fact that incentives have to be targeted to a professional group, like a team environment, rather than to a specific professional group. We have to think about a team environment where there are interprofessionals that are working to achieve optimal patient care.